one of the cells that we find in blood, which most of the time we seem not to know so much about. Now, going back into history, the clot cell, or the cell we call the thrombocyte, or the platelet, was at first assumed to just be some dust particles that were found in the blood, and its significance was not known. So it took quite a number of years before what those particular particles that were being seen in the blood actually were meant for and the role that they play in the blood. If we look at the screen now, in this film, we can just see a lot of red cells. Yeah, so all these are red cells in the background. But then aside the red cells, we have these other smaller bodies, which stain a bit more purple in color. And there are also quite a number of them. So these are cells that are referred to as platelets or clot cells. The name clot cell came about when it was discovered that their major function was in helping to arrest bleeding. Although there are other functions of platelets which are not that popular, but then platelets have other functions apart from helping in the process of arresting bleeding. So one of the disorders that we find in blood with respect to platelets is when we have reduced numbers of these platelets. So we generally refer to that phenomenon as thrombocytopenia. However, there is another form of thrombocytopenia, which we might say that this is a false thrombocytopenia, meaning that it is artificial. Or what it means is that in circulation or in the body, the platelet numbers are not actually reduced. But then this thrombocytopenia was only created as a result of something that happened to the blood sample after it was taken out of the body. And that is what is resulting in the thrombocytopenia. Other times too, the amount of platelets or the numbers of platelets in the sample are adequate. But then when you run your sample through the analyzer, other factors which may be analyzer, dependent, is what is causing that thrombocytopenia or pseudothrombocytopenia. So here we want to look at thrombocytopenia generally, and then would narrow down to pseudothrombocytopenia to find out what could be responsible for this thrombocytopenia. So from henceforth, what this means is that if at any point in time you run a full blood count and you see a low platelet count, don't just, give out your reports without doing due diligence to find out what exactly is responsible for the low platelet count I have for the patient. And even as quality control measure, anytime you run a sample and you have the platelet count or any of the other parameters, particularly the cell count being low, you don't end there. You need to actually repeat the run to see if you still get the same results. And if it's still the same results, you may have to check if something else happened to the sample, for which reason you are getting that, because the patient may not actually be having that particular situation, but it is something that might have happened to the sample after it was taken out of the blood vessel. So this will be the outline for today's presentation. All right, we cannot talk about platelets without going back into the processes that result in the formation of platelets. So generally, when it comes to the development of the cells in the blood or the formed elements of blood, which we call hematopoiesis, we all need to understand the fact that in adults or when a child is born, hematopoiesis is limited to the bone marrow. But before then, hematopoiesis is actually also found happening in other organs of the body, like the liver, the spleen, and the yolk sac. So within the bone marrow space, you have various conditions that support the thriving of the cells which produce or that give rise to the various blood cells. And we have the earliest, most recognizable form, so the earliest form of the blood cell, which in this case is an undifferentiated cell, which has the potential of forming all the various cells of the blood, which we call the hematopoietic stem cell.
This is what I'm talking about.
So the hematopoietic stem cell further differentiates into a multipotent stem cell. And out of this multipotent stem cells, you can also derive other committed progenitor cells. So the earliest recognizable form of a cell lineage that would produce platelets is what we call the megakaryoblast. The megakaryoblast. So this megakaryoblast further differentiates into the megakaryocyte. And the megakaryocyte happens to be the largest cell. In actual fact, it's like a very giant cell found in the bone marrow space. It's the largest cell you'll find within the bone marrow space. And out of this megakaryocyte, you produce platelets. Now, in the case where enough platelets are not being produced, we may need to also look at the bone marrow, because within the bone marrow, we have various stromal cells. These stromal cells release various growth factors or cytokines that support the growth of all the types of blood cells we have in the bone marrow. And so if there's any defect of these stromal cells and they are not releasing the needed cytokines or the needed growth factors, then you will not have maturation of the megakaryocyte of the megakaryoblast to the megakaryocyte and then to the formation of platelets. And if there's also a defect or anything suppressing the hematopoietic stem cell too, may also result in you having reduced numbers of blood cells within the blood film. So, like I did mention earlier, out of the hematopoietic stem cell, you form a multiprogenitor stem cell, which via the activity of various factors, you end up forming the committed megakaryoblast, which is the earliest recognizable form of a platelet within the bone marrow, out of which arises the megakaryocyte. So the megakaryoblast usually is a primitive cell which has just one nucleus, so it's mononuclear. However, the megakaryocyte is a giant cell which has a very special way of maturation and development, in that the nucleus of this cell divides without the cell dividing. Usually, anytime you have a nucleus of a cell dividing, it means that the cell itself is going to divide. But in this case, the nucleus divides without the cell dividing, and we call this endomitotic synchronous maturation. Endomitotic synchronous maturation. So what rather happens is that as the nucleus divides, but the cell doesn't divide, this leads to the expansion of the cytoplasm and the contents of the cytoplasm of the megakaryocyte. And so later on, as you have the megakaryocyte cytoplasm maturing with a lot of granules in there, these granules are shed out through finger-like projections, which we call pseudopods. And I think I'll show you from the next slide. So over here, we can see the megakaryocyte as it has, expanded in its size and all that. It produces some pseudopods which are able to, penetrate the blood vessels. And when they penetrate the blood vessels, as these pseudopods are hit by, the force of the flowing blood through the blood vessels, it breaks off the pseudopods into small, plates. So that's how the name came by, and we call them platelets. So it's like you have those pseudopods being broken, like how when a plate falls and shatters, you have bits and pieces of the plates. So that's how we got the name platelets. So that's how the whole thing happens. And then you have platelets being shed into the bloodstream. However, these granules actually take on the membrane of the megakaryocyte. So they still maintain all features of a cell. The only difference is that they lack a nucleus. So these platelets are non-nucleated. All right. So because megakaryocytes are so large, I mentioned that they are the largest cell within the bone marrow. So they cannot actually leave the bone marrow. So rather, they will extend their projections, their foot-like projections through the endothelial cells that line the blood vessels. And then as the force of the blood moves against these pseudopods or these foot-like projections, it breaks into cell fragments that we call platelets. And we have up to between 150 to 400 platelets in an adult. However, it's not all the platelets in the blood that or in the body that we would have in the bloodstream or in the peripheral blood. So only 2/3 of the platelet population is found in the peripheral blood, and 1/3 of it is found in the spleen. And so if any person at any point in time has the spleen removed, this causes an increase in the numbers of platelets in the blood because the 1/3 that is usually kept in the spleen are all now released into the circulation. Now, platelets have a lifespan, which is 8 to 10 days, and their basic or one of their most significant functions is helping to form what we call the primary hemostatic plug. And so when they play this role, it helps to limit the flow of blood or the loss of blood at any site of injury, especially if it involves an injury to the blood vessel. So there are things that would cause or factors that would cause, clotting of blood to be initiated. And one of them is having a damaged blood vessels. Now, within the blood vessels, platelets usually are found closest to the blood vessel wall. And so anytime there is loss of blood, they are the first to assemble at the site where the damage has taken place. And anytime there's also an impaired blood flow, this also results in congestion of blood. That would also cause a lot of platelets to gather at the sites where this stasis has occurred. And then also atherosclerotic plaques can also, cause platelets to adhere to them and initiate clotting. And then anytime you have inflammation of the blood vessels, that could also lead to activation of platelets and, the beginning of, the clotting process. However, platelets also would require other factors that would help them to be able to take part in the clotting process. So because clotting actually involves proteins, which we call coagulation factors. Some other soluble agents in blood are needed to help with either the formation of some of these factors, and then some of them also actually play a role in the coagulation cascade. So when you have some of these factors decrease in quantities, it can lead to, having an ineffective clot formation. So these factors include calcium and then vitamin K. So again, we want to look at the platelet function. The primary function I did mention earlier is that they are involved in forming of a primary hemostatic plug. So anytime there's a damage to a blood vessel, platelets are first to reach the site because they are closest to the blood vessel wall. So they adhere to the endothelium, and after following adhesion to the endothelium, they are activated and they change their shape, and then they aggregate, and they also even release various factors that will cause more platelets to be brought to the site. And then all these platelets come together to form a temporary plug that will block the blood vessel and preventing the loss of more blood. Then the second function of platelets is that their surfaces act as, a substrate on which the various coagulation factors act. And so when they release the contents of their granules, various factors which support clotting are released. And the end of all the coagulation reaction or the clotting reaction is the formation of fibrin. So fibrin comes in to consolidate and to make firmer the platelet block, not to allow further, loss of blood. And until the site which has been injured is totally repaired, you don't have any more blood being able to ooze out of the blood vessel. So over here, we can see the process of a platelet moving close to the endothelium, and then following an injury to the site, you have platelets rolling over to the endothelial surface. In this case, they are exposed to the subendothelium. And at the subendothelium, they adhere by binding to von Willebrand factor, which in turn also binds to the collagen fibrils, which are found within the subendothelium. Once this is done, the platelets end up changing their shape. Looking at this picture, they become more flat. And becoming more flat helps them to cover a lot of ground, sealing off the place where the vessel is injured, causing more blood to be lost. Following doing this, they release their content, and then the content also helps to attract more platelets to the site. So one of the contents that they release that cause attraction of more platelets to the site is ADP. So ADP is released, and ADP helps to attract more platelets, which come to aggregate at the site. Now, interaction or aggregation of platelets also involves interaction between some platelet glycoproteins or some platelet receptors. And these are usually the platelet glycoprotein 2B and 3A. They interact with the platelet surface as well as with some other clotting factors. Now, with as many as platelets as are come to aggregate around the site, it still is not strong enough to prevent the loss of blood until you form fibrin. So fibrin is the green structures that we are finding in here. So this comes in to strengthen the platelet plug. This initial plug can even be washed away by the shear force of the blood as it passes through the blood vessel. However, when you have fibrin coming in, you form a very strong plug that cannot be taken off. So the second function of platelets involves wound healing. So assuming there was a disruption of the blood vessel causing the loss of blood, yes, a wound is created at the site and it needs to be healed. If we look at this place carefully, we realize that some of the endothelial cells are lost, and some of the subendothelial lining is also lost during the process of injury or when an injury occurs. And so there's a need for the body or the blood vessels to recover all these cells and to seal up the place completely. And so platelets also release various growth factors which support wound healing, such as the platelet-derived growth factor, the transforming growth factor beta, as well as the vascular endothelial growth factor and the dermal growth factors. And then also, not only do they release these growth factors, but then they also promote the formation of blood vessels, or new blood vessels are also produced. And as much as you have new blood vessels produced, blood vessels carry blood which bring in nutrients, they bring in oxygen, they bring in various factors which are needed for tissue growth. And so this enhances the repair of the tissue, and then also the synthesis of collagen to replace what was lost in the injury. The third function of platelets is in inflammation and immunity. So anytime platelets are activated and they release their granules, they also cause the production of chemokines. So if we say chemokines, chemokines are molecules which usually serve as attractants, or they help to guide other cells to a site where they are needed to be. And then cytokines are general, as in these are various molecules which help various cells to interact with each other. So, for example, if there is an injury and you need cells to move to the site to, either to fight off an infection or to cause mitosis in the case of tissue repair and what have you, cytokines help all those activities to take place. And then aside that, platelets also release some antimicrobial peptides, which can also help in fighting off infectious agents. Platelets don't work alone. They also interact with white cells as well as with the endothelial cells. So, for example, when it comes to the coagulation, endothelial cells release some coagulation factors that we call, example being the tissue factor. So tissue factor together with factor 7 are able to form what we call the factor 10 activator. And this will help further to form the prothrombin, complex that is going to help break down prothrombin to form thrombin. And then thrombin in turn is going to also cause the breakdown of fibrinogen to form fibrin. So aside that, too, platelets also play a role in recognizing pathogens. So, and this also involves complement activation. So when complement proteins are also activated in this process, they produce some, activated platelet components which are deposited on the surface of the pathogen. And when these substances are found on the surface of the pathogen, it makes it easy for immune cells to recognize that these cells are not from human source, and so they should be destroyed. The fourth function of platelets lies in, vascular integrity. So vascular integrity here simply means to have your blood vessels intact. So here they are able to help with maintaining the integrity of the blood vessels, and then also preventing any kind of spontaneous bleeding. Usually when platelet numbers are below a certain number, usually when they are below 20 times 10 to the power 9 per liter, it can result in you bleeding spontaneously. And then also, they are involved in releasing various factors that help to maintain the strength of the blood vessel walls. Now, platelets also carry a number of things in their granules. So they also take part in storage, or they are involved in storage and transport. So various platelet granules contain varied products which are important for, hemostasis and also for maintaining vascular tone as well as other functions. So they have the alpha granules, which contain various growth factors as well as coagulation proteins. They also have the dense granules that contain ADP, calcium, and serotonin. So serotonin is a vasodilator. In this case, initially, or an initial protein that is converted to serotonin, that is 5-hydroxytryptamine, is also stored in the platelets. Tryptophan is 5-hydroxytryptophan is stored in the platelets, and it is converted to 5-hydroxytryptamine, which is the same as the serotonin. And then also there are various lysosomal enzymes which are also found within platelet granules, and these are all important when it comes to fighting off infections in the body. Aside that, too, platelets help to maintain the vascular tone. So if we talk about vascular tone, we are looking at things that regulate how blood vessels constrict and dilate. So for example, they release thromboxane A2, which is a vasoconstrictor, and then we also have serotonin, which is a vasodilator, and then we have other vasoactive substances which are also released by the platelets. So in the past, we only knew of just the, hemostatic role of platelets. But with time, research has shown that platelets do all these other things that have been, shown here. So thrombocytopenia refers to when platelet counts are below 150 times 10⁻⁹ per liter, and it is graded as follows. So a mild thrombocytopenia is when you have platelet counts ranging from between 100 to below 150. And that is mild thrombocytopenia. Moderate thrombocytopenia is when it's between 50 to 100, and severe between 20 to 50. And then very severe or critical when it is less than 20. So usually when you have the very severe thrombocytopenia, that is what will lead to spontaneous bleeding. Now, when there is thrombocytopenia, it's important for you to be able to tell what is causing the thrombocytopenia. Hence, it's important to understand and to know by which mechanisms you could have the platelet numbers decreasing. So the mechanisms include a decreased production. Another is increased distraction. And usually the increased distraction, most of the time is peripheral, as in it's increased distraction that is occurring outside the bone marrow, meaning that platelets are produced all right, but then when the platelets get outside the bone marrow, they may end up, getting destroyed faster than expected. Then the third is sequestration. Sequestration simply means to have the platelets being pulled up somewhere, or one would just, in literal terms, we can say that the platelets are being held hostage somewhere. And then the fourth one is pseudothrombocytopenia, which I said is false thrombocytopenia, meaning that in the blood vessels or within the body, we don't have thrombocytopenia. The pseudothrombocytopenia is something that was created artificially following the drawing of blood from the blood vessels. So when it comes to decreased production, a number of things can be responsible for that. So the first is bone marrow failure syndromes. So these are syndromes or conditions that result in suppression of, production of platelets. And examples include aplastic anemia. So in aplastic anemia, all the other blood cell lines are affected as well. So there's anemia, there is leukopenia or reduced white cell count, and there's also reduced platelet count. They have myelodysplastic syndrome. In this case, you have dysplastic changes being shown among all the various blood cell lines. So not just platelets alone, but yes, that can also result in a decreased production. Then you have leukemia. So leukemia is when you have, a malignant transformation of blood cells. But sometimes some of these malignant cells, they end up suppressing other cells which might not have been affected by the mutation. And so that can also cause suppression of platelet production. Then you have viral infections, chief among them HIV and hepatitis C, also causing suppression of platelet production. Then nutritional deficiencies, vitamin B12 and folic acid are very, very, very important when it comes to production of cells generally. So anytime you have nutritional deficiencies of vitamin B12 and folic acid, it actually affects all cell lines, including platelets. Alcohol abuse. Yes, alcohol, in fact, if in our study of pathology, be it systemic pathology or general pathology, you would always hear about alcohol somewhere, because alcohol as a compound is, I would say the body has a higher affinity to use alcohol for energy production than using glucose. However, when we look at the platelet formation, when I was mentioning some of the platelet factors, we saw ADP. ADP is produced when ATP is hydrolyzed. And so but then, alcohol definitely is not found, or anytime someone is using alcohol, it's kind of a temporary thing. You have glucose being left unused, and that results in, various toxicities for the body, and it affects the functions of proteins and all that. And so if you have excess glucose in the system not being used, it could affect proteins that may be involved in various, cellular metabolic activities, as well as signal transduction. And so alcohol has this way of affecting many other body processes if not used in moderation. And so that also would cause a decrease in the production of platelets. Then you have chemotherapy and radiation exposure. Yes, there are some drugs which, when taken, they may form complexes with, platelet proteins, and this may attract the immune system, forming antibodies against these, platelet surface proteins, and that could lead to the early destruction of these platelets. And then radiation exposure to, radiation would disrupt a lot of cellular processes, especially if it is in measures that are not controlled. So all these factors would result in a decreased production of platelets. So sometimes it's important to go beyond just running the test to finding out more, either from the patient history or doing some further investigations to know what is causing the decreased production of the platelets. Secondly, we may have a reduction in the platelet count as a result of an increased peripheral destruction. So the first could be as a result of immune interruption of platelet function and platelet numbers. So examples include primary immune thrombocytopenia. So here we are looking at antibodies being produced against the platelets. causing the early destruction of the platelets. Then we also have the secondary immune thrombocytopenia, which in this case, you are having antibodies not produced directly against the platelets, but these are antibodies produced against other factors, but then they also end up interrupting with, platelet function, like you have in systemic lupus erythematosus, antiphospholipid syndrome, and then some lymphoproliferative disorders. Malaria parasitemia has also been established to result in increased destruction of platelets. So what happens here is that, some malaria proteins end up being deposited on the surface of platelets. And once these platelets are going through the spleen for the normal and the routine checks, they end up being destroyed by macrophages within the spleen, resulting in a reduction in platelet numbers. Then some platelets destruction is also caused by, certain drugs. So we have an example being heparin-induced thrombocytopenia. Heparin is an anticoagulant. However, it could also result in it could form complexes with platelet factor 4. And when this complex is formed, it is seen by the immune system as being something which is foreign. And so these cells are mopped up or they are destroyed from the bloodstream. Then quinidine and vancomycin have also been known to also induce early platelet destruction. Then we also have some causes which are not immune related, So we have an example being disseminated intravascular coagulation, which in this case causes platelets to be consumed very fast because there's a lot of clot formation that occurs in this condition. Thrombotic thrombocytopenic purpura also results in the formation of clots, very widespread formation of clots. And like I made us to know earlier, clot formation cannot occur without platelets because it's on the surface of platelets that the coagulation factors react to form the clots. And then hemolytic uremic syndrome as well causes the trapping and destruction of platelets. And in all these conditions, we have what we call microangiopathy, where small blood vessels end up being lysed with the excessive fibrin that has been formed as a result of the widespread clots. And these fibrin ends up, causing mechanical damage to the platelets. And these platelets also end up being mopped out of the system. HELP syndrome, which is hemolysis, elevated liver enzymes, and low platelet syndrome. That's what has been abbreviated as HELP. So that is hemolysis, elevated liver enzymes, and then low platelet syndrome. Also causes or is involved in, non-immune destruction of platelets. Then we have mechanical, causes of platelet destruction. And this happens when you have some prosthetic heart valves. So within the atria of the heart, the atria have valves. These valves are supposed to prevent the backflow of blood when the blood is being pumped. And so some people end up having some defects of these heart valves. And so they are not able, they end up having what you might call congestive heart failure. So in that case, surgery is performed and some prosthetic heart valves are implanted in those places so that it will prevent the backflow of blood. Now, these prosthetic heart valves also have been established to cause destruction, mechanical destruction of platelets. And so that also adds on to the increased destruction of platelets. Then we have sequestration as the third cause of destruction of platelets. So when you have hyperactivity of the spleen, already we did mention that 1/3 of all the platelets produced in the bone marrow are stored in the spleen. So when there's hypersplenism, this results in further, sequestration of platelets within the spleen. And this could result in, some form of splenomegaly. So it's important to always also trace information from the patient's history. And at least that makes you convinced that the thrombocytopenia that you are getting from your analyzer is actually true and not that it's a false thrombocytopenia. Portal hypertension as well also actually leads to hypersplenism and causes, reduction in the circulating platelets. Cirrhosis is a state in which the synthetic ability of the liver is reduced to a very low level, and platelets are produced by the activation of a platelet hormone called thrombopoietin. And so if the liver is not able to produce proteins as expected, this affects thrombopoietin as well. And so there wouldn't be enough activation of megakaryoblast and megakaryocytes to produce more platelets. And so that could result in reduction of platelets within the bloodstream. Then the fourth one is pseudothrombocytopenia. So pseudothrombocytopenia, like I said, is something, so all the first three that I talked about are things that can happen within the body. They are all being caused by things which are happening within the patient. And so what means is that when you take the patient's blood sample, whatever platelet count the analyzer gives you is as a result of what is truly happening within the body of the patient. And we should also be able to provide information, or we should be able to help the clinician to also understand why the patient is having a low platelet count. But then the fourth cause of low platelet count is a false platelet count, meaning that that is not the true state of the patient. But then this pseudothrombocytopenia has been caused as a result of something happening to the blood after it was taken from the body. So the first cause of this pseudothrombocytopenia are clots. Clots that occur when the blood sample is taken and placed inside the EDTA tube. And usually this is happening during sampling. So these clots could be micro clots, so you cannot see them with, you will not see them readily with your eyes. Some are large clots, which you can see within the sample tube. When you turn the sample tube a bit over, you see that there's a clot inside it. And then you have the full clot, which in this case, you realize that the whole tube with the blood has become solid. And the blood is not even moving properly. Okay. So this happens during sampling. Then we also have EDTA, ethylene diamine tetraacetic acid, which is the most commonly used anticoagulant for hematological, samples, also inducing platelet clumping. So we'll look at these in detail a little later. Then you also have giant platelets. Giant platelets. So these giant platelets are, like the name depicts, yes, they are very large platelets, and these, unfortunately, although this is causing a pseudothrombocytopenia, actually is something that is happening within the body of the patient. And then the last one is platelet satellitism, which is also an artificial phenomenon, as in it is not something which is actually occurring in the patient, but it is happening within the tube, the test tube in which the sample has been collected. So now what we want to do is, in the case of a thrombocytopenia, which we suspect to be, false or to be artificially created, how do we investigate to tell that we are dealing with a case of pseudothrombocytopenia? Because anytime you are able to establish that you are dealing with pseudothrombocytopenia, what it means is that you will need to take a fresh sample and rerun the test. So you should be able to identify or be able to establish that the low platelet count you have, it is a false one, it's a pseudothrombocytopenia, and so there's a need to take a fresh sample to rerun. So like I have already mentioned, the clots may range from micro to complete clots. So for a complete clot, if you examine the blood in the EDTA tube, you just realize that there's a very large clot inside the tube. And if you don't examine, so what this actually means is that before you run any sample that comes to the bench, you always need to do that visual inspection of the sample before you run them. Because sometimes the danger is that if you don't examine some samples before you run them and there are clots in them, they may go and obstruct one of the tubings within your hematology analyzer. And when that happens, you are going to end up with what we call a systematic error. They would consistently cause, error in your blood cell counts for many samples that you are going to run within the day. So that is a very, very important thing to always do. That visual inspection of the blood. Now, if you don't see any clots, either the complete or the large clots, and you go on and you have run your sample, but then you have a low platelet count, you may want to rule out the presence of microclots or fibrin strands within the sample. Now, how do you check for the microclots or fibrin strands? You employ an orange stick. So this stick, we refer to it as an orange stick. You place it inside your blood and then you just turn it around a bit and you bring it out. If there are any fibrin strands or microclots, you will see them on the orange stick. They will be trapped by this orange stick. You just see them on the orange stick. And at least that will give you an idea that you are dealing with some microclots or fibrin strands, which also means that some clotting has taken place. Once clotting takes place, it means that platelets will be used up. And so that could be why you are experiencing or you're having a low platelet count. Now, the second one is EDTA-induced clamping, platelet clamping. So over here, from these pictures, we can see a number of, platelet clamping, which are as a result of the EDTA. However, you usually wouldn't see this happen if you take the treated sample. So if you want to be sure whether this is a true or a non-EDTA-induced platelet clamping, then you may want to take the sample of the same patient and put it into EDTA blood and see whether when you prepare the film, you are still going to see this kind of platelet clamping. Usually, you will not see any platelet clamping when you put it in the citrate. This is not to say that we recommend the use of citrate for full blood counts. No. Citrate is not recommended for full blood count. And there are reasons why we don't use citrate for full blood count. But then in this case, you are only using it to support the idea that you are using it to support the idea that there is the clumping of the platelets is as a result of the EDTA. Now, also let's note that usually a citrate tube contains the citrate anticoagulant, which usually you have to add a certain volume of blood to it. So usually there's a ratio of 1:9. 1 part of the anticoagulant to 9 volumes or 9 parts of the blood. So what it also means is that if you should put your sample in the citrate tube and you rerun on the analyzer, whatever value that it will give you for the platelets, you have to multiply it by 10 to give you the true platelet count, because the citrate, in this case, dilutes the blood. Then the third is platelet satellitism. But let me say that with respect to the EDTA-induced platelet clump, you cannot see it unless you prepare a blood film. So there's a need for us to always go back or to check a blood film for us to be able to identify some of these challenges. Otherwise, we will not be able to identify them if you only just run on the analyzer and then you want to issue out your report. So platelet satellitism is a phenomenon in which you have platelets usually surrounding neutrophils and in some cases basophils in the blood film. So what it simply means is that if you have platelets surrounding a neutrophil like we see in this picture, or a basophil, what it means is that these platelets will not be available for counting. They will not be available for counting. And you know the principle by which the hematology analyzer works. It works like a flow cytometer where all the blood cells are made to, file or to form a single file and go through a certain aperture to be counted singly. So if you have the neutrophils being, attracted or surrounding a neutrophil like this, that means that this particular neutrophil will just go through that aperture with all these platelets also surrounding it to go through the aperture at once. And so these platelets will not be seen and counted as platelets. They all just be counted as just one cell which is passing through the aperture. Now, there's no definite causal association of seeing platelet satellitism with any kind of disease. However, the cause may be immunological or non-immunological. It's not been clearly established. And like I said, satellitism is seen most of the time with neutrophils, or you have the platelets surrounding a neutrophil and occasionally a basophil. So this phenomenon is also not seen when you put your sample in a whole blood, so in a citrate tube. And then if you also take a blood directly to prepare a film, you would also not see this satellitism occurring. So it's been established that there could be something. Either the neutrophil may be releasing a substance that attracts platelets around it. It's not been clearly established what causes that. But it's also been established that when you add 20 milligrams per ml of kanamycin to EDTA anticoagulated blood, which is showing platelet satellitism, it causes the dispersion of the platelets from the neutrophil. It causes dispersion of the platelets from the neutrophil. And so you can, when that has been done, you can rerun your platelet count again on the analyzer, and you would expect the results to be different. And this is also similar to when you run a full blood count and then you see the MCHC value to have increased. And so you suspect that it could be as a result of the presence of some cold agglutinin. And so you realize that the parameters and the way the results appear, if you follow up by incubating your sample in a water bath set at 7 degrees Celsius for about 15 minutes and then rerun, and you realize that the MCHC value changes to normal. So in the same way, a remedy that has been found for platelet catalytism is that you add 20 milligram per ml of blood to the EDTA anticoagulated blood, and that would disperse the platelets from around the neutrophil, and you would get your correct platelet count. Now, the last one is the presence of giant platelets. So if we go through this film that we have here, the first film here shows the presence of normal size platelets. Then in B and C, we see some platelets which are hypogranular, and some of them don't even have any granules in them. And some don't even have any granules in them. That is in B and C. And then in D, we see a giant platelet. You can see that this platelet is even bigger than the size of the red cells here. Then in E, we have platelets of varying sizes. So we have some large platelets, and then we have some normal size platelets as well. So this is in a condition, or this in a patient having a condition called primary myelofibrosis. And then in the last one too, we also have anisocytosis of platelets, as in varying sizes of platelets. But here we have a giant platelet. You can see that the size is about the size of a red cell, and then you have smaller red cells, and then some of the you have smaller platelets, and some of the platelets here are large, but they are hypogranular. Okay, so this was in a patient who has a condition called essential thrombocytopenia. This is a condition that causes an increased platelet count. So in the peripheral blood smears, the platelet size can be interpreted by comparing the platelet diameter with the diameter of red blood cells. So large platelets usually range between 3 to 7 microns, and we call them macrothrombocytes. And then platelets that reach the size of a red cell or the size of a lymphocyte that is measuring between 7 to 20 microns are designated giant platelets. It is normal to find some giant platelets or some large platelets in healthy subjects, but these are usually less than 5%. 5% of all the platelets that you find in them. So what this means is that if you find giant platelets, they will not be counted by the analyzer as being platelets. They'll be counted as being red cells. They'll be counted as being red cells. And so at the end of the day, although you are having platelets whose numbers should not be recorded as being small, you end up having a reduced platelet count. And so what this means is that you still need to go to the blood film to be able to exclude some of these, to be able to tell whether the thrombocytopenia or the low platelet count you are seeing is really true or not. So in investigating thrombocytopenia, it's important to take note of these key investigation steps. So it's important to have a detailed history of the patient. So this would cover various medications if the person has had any infections, if the person has any systemic symptoms, which would point to thrombocytopenia. And then physical exam would also be important, where you look out for lymphadenopathy and hepatosplenomegaly. Then, of course, carrying out the complete blood count and additionally looking or examining the blood film is also important. And then you may have to do additional testing, and that could include doing a bone marrow biopsy, doing some, serological screening for autoantibodies, also checking for viral infections. Earlier on, we had mentioned HIV and hepatitis C. And then, of course, carrying out coagulation studies. If you carry out coagulation studies, particularly measure the levels of D-dimer, which tells you how much clotting has actually taken place. It will let you have an idea what could be, informing the low platelet count. So if you suspect, if there's thrombocytopenia and you examine the peripheral blood smear, if you observe platelet clumping, you may want to establish whether it is an artifactual thrombocytopenia, which is the same as what we call the pseudothrombocytopenia. If it happens that there is true thrombocytopenia, if there are giant cells and also some white blood cell inclusion bodies, then it's likely to be a hereditary thrombocytopenia. And again, if it's true thrombocytopenia and you find schistocytes, then this could point to what we call microangiopathic hemolytic anemia, which in this case, it could be as a result of TTP, that is thrombotic thrombocytopenic purpura, the hemolytic uremic syndrome, or disseminated intravascular coagulation. And all these investigations here can help you to confirm which of these is responsible for the low platelet count. So LDH, bilirubin, haptoglobin, PTA, PTT, D-dimer, as well as fibrinogen. Then if you will also examine a blood film and you come across blast, nucleated RBC, the pegahuate anomaly in neutrophils, and the presence of teardrop cells, which we call them dacryocytes, among others, then it could be as a result of a primary bone marrow disorder. In that case, you may need to do a bone marrow aspirate and biopsy. Now, if you happen to come across microspherocytes with RBC clamping or agglutination, then you could consider Evans syndrome. In that case, if you run your direct antiglobulin test, reticulocytes, LDH, and bilirubin, it would help you to confirm the diagnosis. If it is thrombocytopenia with lymphocytosis, presence of atypical lymphocytes, neutrophilia, toxic granulation, etc., then you could consider infection. So other tests that you could carry out would include the ESR, CRP, a chest X-ray, some tests for viruses, and then some blood cultures as well would help you to tell whether it's an infection which has resulted in this thrombocytopenia. And then lastly, if you have an isolated thrombocytopenia, meaning that with a full blood count, it's just thrombocytopenia, that is the only abnormality you are seeing. There's no anemia, there is no reduced white cell count, or there's no increased white cell count. Then, in that case, you can suspect the immune thrombocytopenia. You can also suspect HIV, hepatitis C, H. pylori, heparin-induced thrombocytopenia, DIC, as in disseminated intravascular coagulation, as well as any intestinal causes. And then you would further carry out investigations based on other clinical assessments to, confirm what is causing the isolated thrombocytopenia. So here I would like to, remind all of us that investigating thrombocytopenia is a must. It's our responsibility. We shouldn't just run the full blood count and then just send results to clinicians without trying to do some of these checks. And the thing is that if you suspect something which requires further investigation, we know, yes, of course, you cannot just get up and be running tests for free for patients because you suspect something. But what you can do is when your full blood count report is to go, you can put some comments on the report and suggest to the doctor that you recommend that we should carry out these further tests to try and establish the cause of the thrombocytopenia. When such a report gets to the doctor, the message that sends to him is that, look, my counterpart or my colleague in the lab really knows what he or she is about. And so they know that they can rely on you as a counterpart who can help them to help diagnose patients well. They will not just assume or see you to be a robot in the lab who, when we say we want full blood count, you just run full blood count and send report to them without trying to help them further to interpret the results or to help them to confirm diagnosis. Now, anytime you run a full blood count and you see there's anemia, there is reduced white cell count, there is thrombocytopenia, there's an increased white cell count, and so on and so forth. Those are clinical manifestations of a disease condition. And so ours is to go further to help the clinicians to decipher what could be causing that to happen. So our work doesn't stop with you just carrying out the test and forwarding results. So I hope that in our next presentation, where we are going to look at, spotlighting the allied health professional, we are going to learn the things that we should do in our practices that would help other people within the health sector, other professionals within the health sector to see how useful we are. And so for that matter, we are able to take our place, where we need to find ourselves. And we gain the needed recognition that we ought to as professional medical laboratory scientists. So without further ado, I'm going to stop here and then I'm going to ask for your questions, your comments, and suggestions. Thank you very much.
Thank you very much, Doc. That was very insightful. To my colleagues and audience, please, if you have any question, kindly unmute yourself and ask your question. Hello, am I audible? Can you guys hear me?
Yes, please, we can hear you.
Abeg, Doc is done. Please ask your questions. Emmanuel, what do you have questions? It's like your mic is unmuted. Kindly ask your questions. Dog is waiting.
No, I know the question. Sorry. Okay, I think Joseph Abdul Amin.
Joseph Abdul Amin.
Yeah. Good evening.
Yeah, good
Thank you,
evening, Joseph.
thank you very much, Doc, for this program. It's really been entertaining and really been insightful. And my question is, you see, sometimes you will draw a blood sample, during phlebotomy, you draw a blood sample, and then right after drawing it, you pull it into the EDTA tube. But later on, you find out there's a clot inside, and the side of the clot might not actually be able to pass through the needle. So I really want to ask what really causes that? Is it that there is the EDTA, there is a problem with the EDTA, or it's sometimes intravenous? I really want to know about that. Thank you.
All right, thank you very much, Joseph. So if I go to your question, you are saying that the blood is drawn into the syringe, and when you are dispersing the blood into the EDTA tube, you realize that the blood is not able to flow out well because a clot has been formed in the syringe. Is that what your question is?
No, the clot will not be found in the syringe, but rather when after pulling it into the EDTA tube, you find out that there's a clot inside the EDTA tube.
Okay. Okay. So I can think of two things in this case. So one of them is either the EDTA that is inside the tube is a bit defective or is not up to the right concentration. You know, the EDTA tubes here, they are produced in a factory. Of course, there could be some errors sometimes, which will not allow a particular EDTA tube to contain the right amount of anticoagulants. And then on the other hand, too, there could also be a pathological condition where a patient is having a pathological condition whereby he or she may be forming a lot of clots in the blood. So in that case, although the blood has been put into EDTA, some of the clots were already present before, or the clotting process is actually ongoing before the blood was even drawn from the blood vessel. So in that case, you may need to, further establish whether the patient is not having any of these pathologies that could cause an increase in clotting. For example, deep vein thrombosis. Okay. So in that case, you may want to carry out a test like, the D dimer test to see the extent of fibrin degradation. On the other hand, you may also decide to draw the blood and put it in a citrate tube to find out whether you are still going to see the same clotting occurring. At least that will help you to rule out that the problem is not with, let's say, the EDTA tube. But then you could also decide to use another EDTA tube and put the blood sample into it to see whether you are going to experience the same clot. That's just to rule out that maybe the problem was just the EDTA tube that you used. But then if you are very certain that after the blood was placed in the EDTA tube, the blood was properly mixed on time, then of course you would want to look out for any other thing that could have caused, the clot formation to have occurred. That's fast or that's early.
Thank you very much, sir.
All right.
Thank you very much, Doc. Any other person? Does anyone have suggestions? If no questions, okay. Doc, I think everybody is satisfied with today's session. Because it seems no one has any other questions to ask. So I would like to say thank you very much for joining in today's call. And thank you for having time for us. And thank you again for doing this with us. We are so grateful. And to everyone on the call, thank you for joining in today's session. I'll meet you tomorrow, same time. Thank you. Enjoy the rest of the day. Bye.
All right. Thank you too.
Thank you, Doc. We'll keep in touch.
All right.